conventional medicine has done amazing things, but we've hit a roadblock. I was just feeling like I'm not doing a good job. Like I'm not helping women the way I want to help women. And functional medicine really helped me kind of put the whole picture together of how to care for people in a more holistic way.
This is Sick Health with Kevin Ban, MD. Our show helps you navigate our confusing healthcare system so you can take control of your own health. I just had a great conversation with Sarah Della Torre. We start off with not all wandering is necessarily lost. And then we get into some specifics about menopause, how it impacts sleep, how it impacts weight gain and behavioral health, specifically anxiety and depression. It was a really interesting, deep conversation with a person who has so much experience. Sarah started in OBGYN, but then she transitioned into functional medicine, lifestyle medicine. She's got her own wellness clinic. It's called Lumani Wellness in Sun Valley, Idaho. She works with women's hormonal health. And recently, Sarah's been working with Halle Berry. And there, the concept is that they want to see a woman's second chapter be even better than her first. And now, without further ado, Sarah Della Torre. So you drink tea in the morning?
Yeah, I drink tea in the morning. I feel sometimes like a little old lady, but yeah, I love it.
I'll tell you, that makes me an old man because every night now I've been drinking tea.
Is it like nighty-night tea?
Yeah, it's nighttime tea. It's like nighty-night tea.
With valerian root? That stuff is the bomb.
I don't know if the tea at night has anything to do with how well I sleep, but it has become a part of the wind down exercise.
Yeah, you're getting a nice little bedtime ritual helping you sleep. Yeah, we talk about that a lot with menopausal women, actually, because sleep it's pretty hard to find in midlife.
Well, if we do our jobs today, we will go there. We will talk about how menopause not only impacts sleep and weight gain, anxiety, depression, but some things that you can do to understand why that is, and then some things you can do to sort of change that. But before we do any of it, I want to talk about you.
I had this wayward path to medicine. I don't know, Kevin, if you just went straight through.
No, I was always amazed by those people.
Yeah.
But thank God for that concept, not all wandering is lost, because I'm one of those guys who, mine was a journey, and it sounds like you were too. So what was the journey?
Well, I love that. And I was surrounded by people who went straight through. So I always felt a little bad about myself until I got older. I thought, no, this is amazing. Like I've done some things besides just been in school. So I started off at the University of Puget Sound in Tacoma, Washington. I don't know if I was too immature to leave home, but I kind of hated it. I gained the freshman 15. I was a little depressed. I was like, what am I doing? So I left there, went back to New Mexico, did one semester at University of New Mexico and thought, this is lame. I don't know what I'm doing. So I quit and I moved to Milwaukee. And I was 19. I was bartending. And then after about 4 or 5 months, I'm like, gosh, it is really cold in Milwaukee. I don't love this. Went back to New Mexico. And then somehow I fell into emergency medicine and started working for Albuquerque Ambulance. So I was 21 driving the ambulance. So a lot of craziness at that age. And then thought, as I dropping patients off at the ER, I wanted to stay in the trauma room, right? I wanted to see what was going on. So that was my first inkling of, okay, maybe I want to be a doctor. Maybe I want to do more. And then actually before I graduated college, I took off one more year. I quit again. And by now my parents are sort of like, what is going on with you?
She had so much promise. She seemed to be...
They're like, you were an athlete and a student. What happened to you? But then I was a ski bum for a couple of seasons and then finished and then went to medical school. And then a little bit of the rest is history.
I want to react to this because here I have a kindred spirit. As I was finishing high school, I didn't know what I really wanted to do. So I took a year off. And now that's affectionately referred to as a gap year, right? But back then it was like, he's fucking up his life year, right?
Exactly.
And in my mind, there was no doubt that I would go to college. I just needed to mature a little bit more. All right. So you end up finally finishing college and going to medical school.
I went to UNM. University of New Mexico. And then like once I found my groove, I was in it. Like I was working, doing dispatch and still studying and top of my class. And I had convinced myself I wanted to go to the most competitive program on the West Coast, an OBGYN. So I matched at University of Washington. It was an incredibly rigorous program, which I really appreciate at this point. And then started in a private practice in Seattle where I was for about 18 years until recently.
And then a big change. So what was that transition?
Well, the life of an OB/GYN is pretty tough. You work all hours of the night. You know, we do 24-hour shifts and I was raising my kids, but 10 years into that practice, really had a thriving practice, loved taking care of women, loved delivering babies, loved doing surgery. Was getting a little burned out. I started feeling pretty frustrated that I wasn't offering women enough of an answer in their health. So, like menopause is a great example, but also PCOS or women who had abnormal bleeding. It was just like give everybody a birth control pill was kind of the answer. And not being a huge fan of the birth control pill in general, I thought, God, is this really all we have for women? This is crazy. And so, from somewhat of frustration in my level of knowledge. And then also feeling like, gosh, a little deflated when patients left. And I thought, I didn't really help that woman that much. And so I went on this path of figuring out what resonated more with my personal and professional values of helping more, knowing more. I grew up in a really, my mom is like a hippie mom. So we had no sugar in the house. And she was putting cottage cheese in our scrambled eggs and brewer's yeast on her plain yogurt, right? So this is the household that I grew up in. And I knew like a lot of taking care of ourselves is how we're living. And so functional medicine really appealed to me from that standpoint because we look at the root cause of what's going on. We don't just say, oh, Kevin, you've got some acid, some heartburn. Let's put you on omeprazole, right? It's like, no, why do you have acid? Do you have too much acid? Do you have too little acid? What's going on in your microbiome? So I went and got certified in functional medicine and loved it. It kind of reignited my passion for medicine.
You know, one of the things I've talked about a bunch on this show is how we tend to be very focused on treating illness and less concerned about trying to prevent it or even understand the root cause of the illness, which is exactly what you're talking about right now. Many people talk about this, but I don't know a lot of people who go through traditional training and then go out and get certified in functional medicine. That's notable. What motivates that?
Well, I think it was just feeling like I'm not doing a good job. Like I'm not helping women the way I want to help women. And my sense of self and my personal values were very much lifestyle is everything. And to me, conventional medicine has done amazing things, but we've hit a roadblock. Patients don't have a lot of time with their doctors. Doctors are overworked and stressed, burned out. And then we're just giving medicine for everything. It's like, here's a pill, here's a pill. I went and saw my primary care here, and I really appreciate her. But everything was, well, why don't you just take this? Like, why don't you take this for sleep? And I was like, I don't want to take a pill. Like, I want to solve this without a pharmaceutical if I can. So for me, it was just that drive of, I feel like I'm missing a piece of the puzzle here. And functional medicine gave me that piece in a lot of ways. It really helped me put the whole picture together of how to care for people in a more holistic way.
I mean, I think that's really cool. And I would say that I feel like you got to thread a needle on functional medicine. I love that they're looking to understand root cause and aren't simply treating the symptoms. However, one of the criticisms that comes is that oftentimes in functional medicine, there are a bunch of very expensive tests that happen, which are followed by a bunch of very expensive supplements that, hey, by the way, I'm going to sell to you. And it's unclear to people where the value is there. So
Right.
how have you reconciled that in the way you practice?
I like to say I'm functional medicine light. Like I really love the principles and I love discovering and talking about the root cause. I don't tend to run a lot of tests. I don't think that they're always useful. There's a role for it, absolutely. But I don't go really deep into a lot of expensive tests. I do like supplements, but I'm very specific about which ones I'm recommending. And I don't pile them all on at once. I don't make money off of them. For me, I thread the needle by Just listening to what makes sense to me, as my own person and how I treat myself, and then what makes sense about what's going on with the person in front of me who's my patient. And if they want to dig deeper, yeah, I can offer all that. Like a lot of people love that data. But I also try to just counsel about what's really necessary and what's going to be helpful and get you to where you want to be.
You don't like to do too much testing, but you like to do the important testing. And that's because you have the experience to actually know when that makes sense. I think the saying goes something like good judgment comes from experience and experience comes from bad judgment type of thing. And
exactly. Yeah. The real thing that switched my life up was I injured my hand. So in 2018, I was playing tennis and this guy rips this ball at me and then I wasn't holding my racket hard enough or something and it bent my finger back and I tore a ligament. And then I had to have surgery and it was a terrible recovery. I couldn't use my hand as well anymore to deliver babies and do surgery.
You got injured and couldn't do the day-to-day work of an OBGYN. And so it gave you an opportunity to think about your career, your life in a different way, which is fascinating to me. And for you, it turned into a totally different career.
Yeah, I mean, hindsight is 2020, right? At the time I was devastated. I thought, what else am I besides an OBGYN? What can I do besides deliver babies? And I loved surgery and all that. It was awful. I had a year of honestly like pretty severe depression and just being down. I didn't work for that year, which I'd never done in my life, right? I'd never taken a year off. And unfortunately, I spent most of it kind of boo-hooing and stressing out. And then I created a position for myself at a fertility clinic with some people that I'd known my whole career, which was amazing opportunity. I learned a lot and treated fertility patients and loved it. That's an amazing life lesson that I have to remind myself of when something happens. It can be devastating temporarily, but there's going to be something that comes of it. You're finding this path, just like your wayward path to medicine and, this path of mine. So I started about 5 years ago, really delving into menopause on my own, just kind of learning about it because I was starting to go through it myself and felt really confused because, we're not trained in medical school and residency. Maybe I got a month of education in 8 years of medical school and OBGYN residency about menopause and felt really ineffective when I was practicing. Fertility is a lot about hormones and, reproductive endocrinology. And then perimenopause and menopause just became, for me, a natural extension of that. And then I just decided I'm going to open up my own practice. I'm just going to really focus on lifestyle and hormones and listening to women. I'm not going to take insurance. I've been doing insurance for 20 plus years. I'm over it. It's going to be a cash-based practice. So I can take the time, really listen, and be very personalized with my patients. And so that's what I've been doing for the last couple of years.
And all of this because of a hand injury. I don't often meet people who take that type of personal impediment or obstacle or crisis and grow from it as much as someone like you has, because now you've focused not only on menopause, but you're really working at a large scale. And I know that recently you have been working with Halle Berry. She has made menopause a really, really important part of what she's doing and the voice that she wants to have. Specifically, my sense is that she wants to be sure that that second act is better than the first act. So what are you doing with Halle Berry?
So let me just tell you a quick story about how I even got to work with her. 10 years ago, a woman named Colette Cordian was my patient. And she's this, single woman who's having a baby and running a company, but she was always very coy about what company she was running or what she was working on. And she would just say, "Oh, I'm an entrepreneur." And I was like, "What does that mean? What are you doing?" Anyway, I deliver her baby. We have a great relationship. And then about 2 months after, I get wind that she's been working on a vaginal product. And I call her up and I was like, "Why didn't you tell me?" And she's like, "Well, I'm in development." Anyway, we start working together. I became a founder with her company, chief medical officer for the last 10 years. And we've been working with red light therapy. And red light therapy is pretty amazing. We have a really powerful at-home device that works for incontinence and atrophy, It's great for menopausal women, perimenopausal women, or postpartum women. We have another line of, intimate products that are clean and pH balanced, things like that. So, we got together, I became the founder, chief medical officer of the company called Joylux. And we've been working hard for the last 10 years. This was before menopause was having its moment. So it was sort of talking to a lot of investors who didn't really care about menopause. Most of them are men, didn't want to talk about it. And then about a year and a half ago, Halle Berry's team comes to us and says she's used your products and she loves them. And menopause is what she's really working on. She's passionate about it. She's creating a company about it and she wants to join forces. And obviously completely blown away and really excited. We met and she and I have collaborated over the last year to create an intimacy gel and a special edition of our red light therapy device. And Halle is really and truly an amazing person. I'm not saying that just because she's a celebrity. Like, she is kind, she's authentic, and she is incredibly passionate about helping women be educated, be empowered to live their best lives in midlife. So it's been really inspiring. And then with that, she has this company called Respin, which she's launching. And she asked me to be a part of it. So I'm the clinical medical lead. I focus on product development kind of via the lens of my clinical expertise. And what Respin Health is doing, it's essentially a digital health app, and it focuses on care for women in midlife, kind of care and support. And it's harnessing the strength of tech with the power of human touch to help women reframe what it means to be in midlife and how to get the results that they're looking for, whether it's hot flashes or weight gain or mood or sleep or any of the above, right? We're helping them navigate it with support and guidance and education.
I think it's really powerful. What I do want to do is get into some very, very specific tips for people.
Yeah.
I'd love to talk about sleep and weight gain, certainly some of the behavioral health issues like depression and anxiety that come along with menopause. But before we do that, here's a word from our sponsor. C2 Sense is doing important work with its Halo platform, applying technological advances in chemistry, machine vision, and material science to provide both patients and providers with laboratory-level accuracy at low cost when they need it. C2 Sense's goal is to use their patented technology to ensure the same quality of testing you would find in your doctor's office in the comfort of your own home. So if you're suffering from upper respiratory symptoms like cough, sore throat, nasal congestion, or a headache, keep your eyes out for C2 Sense as they're developing tests targeting upper respiratory conditions such as COVID and flu. If you want to learn more, see what they're up to at haloreader.com. I don't know if it's because I'm getting old enough, but like all people talk about is sleep. And if you're a woman and you're talking about sleep, you're talking about how menopause is getting in the way of your sleep. And you've got to be sleeping well so that you have the foundation for diet and exercise. How do you think through it?
Yeah, sleep is key. And what you're saying, if you're not sleeping, you're not going to make good choices the next day, right? You're tired, you need more coffee, you need some carbs. But on the flip side, it's cortisol, right? So you're going to gain more weight if you're not sleeping. You're going to be in a worse mood. So it just compounds perimenopause and menopause and, life in general. But the way I like to explain it to patients is just to really go over what's happening in your body as you are in perimenopause and menopause, because then it kind of makes sense of all the effects it's having on your body. I don't know, Kevin, do you remember the menstrual cycle really well?
Oh, please. No, but let's get into it. I want to know the science here, and I think our listeners do too. And then we'll just make sure that we take all the clicks and pops and put them into English.
Yeah. So the good thing is I can do a pretty good English version. So with your regular menstrual cycle, when a woman is young, she's not perimenopausal, and she has a normal cycle. And I put that in quotations because everybody's a little variant of normal. But in the first half of her cycle, estrogen is building as a follicle, as her brain is telling the ovary, produce an egg, which we also call a follicle. And then the eggs are producing estrogen. So your estrogen level builds to a certain point, and there's a trigger, and then you ovulate, and then progesterone rises. It keeps the lining of the uterus, which has grown with the estrogen, nice and stable. And then if a person doesn't conceive, the hormones drop, the whole cycle starts again, and they shed the lining. So in perimenopause, one of the initial early changes as our ovaries are aging, as our eggs are not as awesome, the progesterone levels decrease in how much is produced. And what that leads to, typically symptomatic wise, is a little more anxiety, especially right before your period, worsening PMS, maybe less sleep. So it's just kind of these early changes that women think, God, my PMS is getting worse, or your periods are changing. They're getting heavier, irregular, maybe shorter, closer together. So that's all from progesterone. That's kind of the initial change, right? And can be really subtle. Everybody's different, or it can be pretty major. And then estrogen starts this crazy fluctuation where it's going really high, way higher than normal, way lower. So that's leading to hot flashes, mood changes, sleep disruptions, joint pain, brain fog, weight gain. We're depositing belly fat because our body needs more estrogen, and testosterone changes to estrogen. And then in our fat tissue, we produce estrogen, right? So the more fat tissue you have, the more estrogen you're going to have. And so that kind of is a survival mechanism that the body's come up with. It sucks. It's a terrible one, right? Because we get all these little pot bellies going on, but there's a reason behind it. So these hormonal changes are affecting women from head to toe, and sleep is a big component of that. And it usually starts early. So the way I talk to women about it is, what is your ritual at sleep? Are all the sleep components in place, meaning you are winding down, you're doing your ritual, you have a cool dark bedroom? Those types of things are important. But most women will look at me and be like, what? That's doing nothing. I need something more.
Yeah, that's one of those things I have to say. Anytime I talk about sleep, I'm like, please don't bother me with the dark, cool room thing. Like, I got that. And so has everyone else listening to this podcast. Like, we get that.
We're over it. Yeah.
And that's not working. So what's next?
Yeah. What I do in my life, separate from hormones, so we'll just pin hormones for a minute and go back to them later. But I like adaptogens for sleep because a lot of it is cortisol based. No one likes the word adrenal fatigue anymore, and they shouldn't. It's not really truly a diagnosis, but the idea is that you're constantly up. Your adrenal glands are constantly producing cortisol. We're just a, high rev society. And so adaptogens help your body basically support that cortisol production, support your stress levels. So adaptogens are typically herbs, plants, plant-based medicine, and they actually do work. There's good data on ashwagandha and rhodiola for stress support. And this is very functional medicine. Like, conventional medicine is starting to get a little bit on board. You can get a supplement, take it. You can just do an ashwagandha tea. Like, there's different ways to do this, but that's a great place to start, is not only, your cool dark bedroom, but what are you putting in your body late at night before bed? Theanine is an amino acid, and that can be really calming. It's not sedating, but it's calming. Phosphatidylserine is similar. That's a phospholipid, which just means it's part of a cell membrane, but it comes in a supplement form, and that can be really calming too. So looking at those types of non-hormonal regimens are really helpful and great. But for a lot of women, you need hormones. That hormone, we used to call it replacement, but sort of hormone therapy really goes far for women. So I like to give women a little progesterone. If they're still cycling, add a little progesterone to the second half of their cycle, just kind of boost their levels. You can test their levels to see where they are, but I just usually add it and see how they feel. Bioidentical is key. I don't use any synthetic hormones. And thankfully, that's becoming more of the norm, is to use bioidentical. And we should probably get into that whole thing of bioidentical, synthetic, FDA, compounded, because it can be a little confusing for people.
And even the whole concept about hormone, I was about to say hormone replacement therapy, but it sounds like you prefer just hormone therapy. That message is getting out, I believe, to women, which is that large study that was done in the early 2000s and was largely misinterpreted. People are getting the message that hormones actually play an important role and can treat a lot of these symptoms and can make people feel better. However, it does feel like some people are having difficulty because it's so embedded that HRT was not a good thing. They have a hard time getting over this hump.
Yeah, the Women's Health Initiative, published in 2002. I was a third-year resident. It was, in my opinion, catastrophic for a whole generation of women. I remember I was in GYN clinic at the time. Hundreds of women were calling, freaked out. Everybody goes off their hormones, right? And that study was very much largely misinterpreted. And the summary of the misinterpretation, or how to reframe it, is that they took women of all ages, much older women, way past menopause, and they put them on hormones, which is not healthy. By then, our blood vessels are more stiff. Estrogen keeps our blood vessels pliable and happy, and our cardiovascular system in a good, healthy place. And the longer we're without it, the more damage can be done. So then you give someone estrogen 10, maybe 15 years after menopause, and especially if they haven't been living a particularly heavy lifestyle, estrogen could cause a heart attack, especially if it's given orally, which is the way it was given then. So the timing hypothesis is huge. And so it's called menopausal hormone therapy now, or just hormone therapy, all about when you start it. And so starting it near, perimenopause, I treat women in perimenopause absolutely with hormones. That's also starting to become the norm, but physicians are slow to get on board with that. And then in early menopause is where you're going to actually make a difference, not only in symptoms, but longevity. So timing is important, and then the type. And the Women's Health Initiative had synthetic hormones. They were using conjugated estrogens, and then Provera, which is a synthetic form. It's a progestin, which means it's a synthetic form of progesterone. It doesn't match our natural hormones that we produce. There's a few, hydroxys, biochemistry switches up. It's not exactly what our body produces. And so I don't prescribe any synthetic hormones, because that's where, in my mind, and what the research is showing, that's where the risk of menopausal hormone therapy comes. The risk of breast cancer, we really think has to do with progestins, not natural progesterone. Estrogen has never been a bad guy with breast cancer, but it got that rap. And so trying to reverse all this from the study has been difficult. And to your point, it is becoming more of a thing. If you're on social media, if you're out there, there's articles in the press, hormones are good for you. The problem is that the most recent studies showed that only less than 5% of women are on them. And granted, it's recently published, but they were studying people from a couple of years ago. So the trend, the pendulum is hopefully swinging. But in my mind, menopausal hormone therapy is key to symptom relief, sleep, monitoring weight gain, mood, but then longevity, bone health, your brain health, your sexual health. All of that is related to having hormone therapy now in perimenopause and menopause.
And just so that we're really clear on this, you've made a great point that people shouldn't be using synthetic hormone therapy. Instead, they should be using biosimilars. And so that's a good question for your provider, right? Like, I don't think people would know to ask that question necessarily, but it seems to matter a great deal.
Yeah. And then it also gets a little confusing for patients and providers alike about bioidentical, synthetic, and then compounded and FDA approved. So most people are associating bioidentical with compounded, meaning it's made in a compounding pharmacy. It's not FDA approved. It's not coming from, an Eli Lilly or whomever, right? It's made in a compounding pharmacy. But FDA approved has an estradiol, which is bioidentical, estradiol patch, cream, ring. There's gel, spray. There's lots of FDA approved bioidentical for those more comfortable in the FDA approved world. And then there's an FDA approved bioidentical progesterone called micronized progesterone, or Prometrium. So there's options out there that are FDA approved and bioidentical. And then you can get into the whole compounding world as well. And those are highly regulated. People have this impression that compounding pharmacies are not regulated and they're just the Wild West. You find a good one, they're highly regulated and they're really good at what they do. I've had great experience for myself and my patients with compounding pharmacies.
So that's where you start. When you're working on sleep with a woman who's having very severe symptoms of menopause, you start with making sure that they're on hormone therapy.
Well, so I think that a really important point to make is that every woman deserves a conversation about menopausal hormone therapy. She may not elect to have it. She might say, that's not for me. What else can you offer me? And that's great. But every woman deserves a conversation. She deserves the information to make the choice of what's best for her body. And what I would love talk about for the vision of women's health in particular, but anybody's health, is for women to start learning to kind of trust their bodies and know their bodies and learn about them and really do what they feel is best for them, but with good education around it, right? As objective, research-based and experience-based as possible, that their provider has the experience to say, hey, here are all the options. Here's what I think you should do, but what sounds good to you?
First of all, I agree wholeheartedly, 100%. I believe that that cuts across all medicine. The
Mm-hmm.
problem that we have is it's exceptionally difficult to get time with your provider. When you make an appointment, it's usually months off. And then you often don't have the time to go deeply into all of these issues.
Right.
You may not even see your doctor. In fact, this happened to my wife for a very long time. She hasn't seen her doctor in a long time. She works exclusively with the nurse practitioner, who's very good, by the way, but also very stressed out in terms of not having much time. It's what you said earlier, which is that you've made the transition from the typical fee-for-service medicine and you've set aside insurance. It sounds like people directly pay you then, but you're also available to them to kind of work through complicated issues.
Exactly. And I think that's what we need. And I don't have a solution right now for the model because insurance to me is not the model. What I'm doing is not available to many people resource wise. So there has to be something in the middle, right? We're insurance based, where we are actually wanting providers to have time with the patients and patients have time to understand these concepts of what's going on in their body. But that I know that's what a lot of your podcast is about, is what's wrong with medicine. And to me, there's so much wrong with medicine. So I'm doing my part in my small, world, in my personal private practice. But then that's what I love about Respin and Joylux and a lot of the people out there on social media talking about it, like educating women, putting it in their face, like menopause, hormone therapy, menopause hormone therapy. Like that's what we need. We need it shouted from the rooftops. This is why I just really admire Halle for using her platform in a huge way to make people talk about it more and educate women about it. Most women don't know where to start, and it can feel pretty defeating if you don't know where to start.
Quite honestly, the way I hear you around hormones is you believe that unless there's really a good reason why a woman ought not be on hormones, and there are good reasons, your advice is that they ought to be on hormones, but that may not solve all of the problems. And so there are other things that you're going to want to address. Who are the people that should not be on hormone therapy? Who are the folks that are listening that should say, like, look, this is a bad idea. This is not the place to start?
Right. Great question. So with hormone therapy, there are a few contraindications, but it also depends on the type of hormone therapy, the route. I don't use oral, I don't use pill form of estrogen. I don't think people should ever be on that. It goes through the first pass metabolism in the liver, increases your clotting factors, has a higher risk for cardiovascular disease and blood clots. So if you kind of take that out and just say, well, transdermal and bioidentical, then most people are really good candidates. But if you have active breast cancer, if you have undiagnosed vaginal bleeding, you have a history of a blood clot, you need to have a conversation. Most people know that breast cancer is an absolute no-no. But if a woman has what's called triple negative, so there's estrogen receptor negative breast cancer and progesterone receptor negative, then she's still a good candidate for hormone replacement therapy. Oh, look, I said it, hormone replacement therapy.
I don't feel so bad now.
I know, you're a bad influence. But there is more and more data coming out that even women who've had a history of breast cancer, that an estrogen receptor positive and progesterone receptor positive, that they're not completely unable to take hormones, but it's a detailed, informed conversation. So those are some of the people that should not take hormones. If you have had a stroke, if you've had a heart attack, it'd be hard to find someone to put you on hormones after those significant events.
You've made a really great case for the conversation, at the very least, about hormone therapy, and that will directly impact your sleep. It'll help with the potbelly, I think you called it, the weight gain,
Mm-hmm.
and then even impact the anxiety that people experience, or depression. After you've ticked that box, what's next?
Just to touch a little bit more on menopausal hormone therapy. So what I would want people to walk away with is it is safe, it is effective in terms of making your current symptoms and life better right now, and then also protecting you for longevity. So my bias is 100% on the hormone therapy train. I don't know what my life would be like if I wasn't on it. I just feel like I'd be a mess in terms of sleep and things like that. So, to be really clear, everyone deserves a conversation. And I really think it's of extreme benefit. And the research is playing that out as well. Couple of points. There's a 50% reduction in cardiovascular risk when women start hormone therapy, and a 30% reduction in all cause mortality when women are on hormones. So it literally can save your life, whether it's a hip fracture when you're 70, preventing that. I just want to really point out for listeners that hormone therapy is a great tool to use. And then to your point, it's not the only tool. So I have women come in, and most of the time they'll say, I feel so much better. Thank you for those hormones. Wow, that's amazing. But I'm not quite where I want to be. And so the point there is that menopausal hormone therapy is not the panacea for everything menopause. And that lifestyle really is important. You actually have to think about what you're putting in your body, how much you're putting in your body. Women just historically undereat. And so, how much and what you're putting in your body, how you're moving. And there's really good data coming out for women in perimenopause and menopause that is specific to us about how we're supposed to move, what we're supposed to eat, because it's really confusing. And most of the research was done on men and then extrapolated to women, which is just not true, right? So, the next step is lifestyle, or in my mind, I like try to put lifestyle first or at this, simultaneously as hormone therapy.
So when you say lifestyle, I'm getting from you that you may be referring to things like the importance of strength training. I think you might be talking about protein and the importance of getting enough protein. What are the other things that people have to be considering?
So when I say lifestyle, to me, it's what are you doing? How are you caring for yourself? And that's a really important subject I want to bring up about women caring for themselves, because that is a calling in midlife. Like, you've raised your kids, you've worked at your job, and we've historically, I would say most women would agree, we tend to put everybody else first, right? The head of the household in the sense of running the household. And so a lot of what women are reflecting back to me in our office visits is they are ready to take care of themselves. They want to. They're kind of annoyed and tired of taking care of everyone else. It's their time, which I think is a beautiful thing about midlife. And I want women to really embrace that wholeheartedly. And so taking care of oneself to me means, how are you feeding yourself? And a lot of women, to the protein point, Kevin, a lot of women will come and be like, I know I'm supposed to eat more protein. They're kind of tired of hearing these things like, I know I'm supposed to strength train, but they kind of want the why. Like, why do I need to eat more protein? Why do I need to strength train? And then how am I going to do it? And that's what I love about Respin. But the why is, protein. We're losing muscle mass as we're getting older. You need the protein. Protein helps with satiety. It helps with sleep. It helps with metabolism. And so protein is really key for women. I tell women, 1.5 to 2 grams of protein per kilogram of body weight divided over your meals during the day. When you eat is really important for women. This time restricted eating, what the research is showing is that it's really good for just specific groups of women, those that are obese or have metabolic issues like true insulin resistance, prediabetes, or diabetes. But for, the rest of the population who aren't in that category, time restricted eating can actually backfire and cause more belly weight gain because of the cortisol and glucose spikes that you're getting. And so eating before you work out, eating within 30 minutes after you work out, and that's specifically for women. Men can go longer, right? So for women, eating specifically within 30 to 40 minutes after you work out. And then, strength training, like lifting heavy, we hear that all the time, but it is a thing. Like, we need to build and maintain our muscle mass. So the idea is you're lifting to the point where you can do, 6 to 10 reps, and that's kind of it. And then you do 2 or 3 sets of that, and you do that 3 times a week, right? Just maintaining that muscle mass is so important for longevity, for brain health, not breaking your hip, all those types of things.
I know many women struggle with the weight gain that accompanies perimenopause and menopause. How do you approach that?
Yeah, it's a huge pain point. It's one of the primary reasons women come and talk to me about perimenopause and menopause, because for so long we're kind of keeping it all together and we've got our routine. And then no matter what you do, you're doing the same things or you're doing even more, and you're gaining weight and you're losing muscle mass. And it's incredibly frustrating. And I'm so empathetic. I've experienced it myself. And it's, you just want to be like, what happened? What happened? So, what happened is these hormonal shifts, including testosterone, right? Estrogen and testosterone are decreasing, progesterone's decreasing, and we just don't maintain muscle mass the way we used to when we were young. And I mean, men are the same way. And so that leads to metabolism changes. And so, what we're finding from the research is that the protein is really important, not giving up carbs, right? Because you need the fuel to exercise. So, having complex carbs still in your nutrition plan, but having the protein or time restricted eating, being careful with that. But the other key thing is how you exercise. And there's been something recently in the last several years about sprint intervals. So we all know HIIT, high intensity interval training, and women will do HIIT for an hour and see no change in their body composition. Whereas if we shorten those HIIT sessions and we do things called sprint intervals or SIT, is that we're seeing changes in the belly fat. It's specifically the belly fat, which again is the main pain point for most women in midlife. And what that looks like is doing sort of a Tabata workout. You only need to do it for 20 minutes, which is great. And you can do it 2 times a week, no more than 3, but 2, I think, is a great sweet spot. So you're doing this where you are all out for 20 to 30 seconds, and then you're off for 20 to 30 seconds, all out. Dr. Stacy Sims is a PhD who's just studies women. And I love listening to her. She's intense, she's smart, she's super fit. And she has a couple of great books. One's called Next Level, and it has a lot of information about eating and exercise and specifically sit, which I highly recommend to women in midlife.
It's funny that you should mention that. I work out with a group of guys every Monday, Wednesday, and Friday, and we have been largely focused on HIIT, the high intensity interval training. And then we lift weights as well. But we have embedded Tabata recently where we're doing like 30 seconds all on, and then we're 15 seconds off. And we're doing that with rowing, we're doing it with spinning, and we're doing it with different weight exercises too. We use dumbbells and we do ground to overhead, and we go as much as we can in that 20 to 30 second period. And then we take some time off. That's really helpful. Let's round this up with mental health. It's such an important part of menopause and some of the most difficult piece of menopause to navigate, specifically anxiety and depression. How do you approach those things as it pertains to menopause?
Yeah, so important and really affects so many women and quite severely. I mean, I have a story of a woman who was an hospitalist and really struggling and talking to her doctor and getting prescribed medications, but then ended up ending her life. And I just think maybe if she had had hormone therapy, would she have done better? Maybe if someone had recognized or helped her recognize that this could be associated with menopause, also obviously life stresses and other things going on, but menopause and perimenopause absolutely take a toll on mental health. And not everyone, but a significant proportion of women, very common to have anxiety at first, but then this feeling of meh is how most women will describe it to me and how I'll bring it up to women. Are you feeling kind of meh? Like you're just not the same motivation in life. And a lot of women will say, well, I'm not really depressed, but I just feel kind of blah. I've got the blahs. And then there's the more severe depression, which again is much more common in midlife in women. And when you think about what midlife is about, and especially for women, I'll just speak to women, not even especially, I'll just speak to women, is, many women are raising a family, their family's nearly raised, right? Kids are leaving. Maybe you still have kids at home, or maybe they're already gone, but that takes a whole lot of energy to do. You potentially are partnered, and relationships take effort. Your parents are aging, that takes effort. You have a job. You've been doing this for a very long time. And most women describe to me that they're just really tired. And add on to the hormonal changes, it's kind of a tsunami of things going on all at once. And so I like to specifically address it with women and really drill down about their mood and have them think about it and describe it to me. And hormone therapy does really help in my mind. Most women come back and say, you gave me that estrogen and I feel like a new person and I'm really grateful and, whatever. I'm like, well, it's the estradiol. That's what's helping you. But the other one part of that is testosterone. I want to use the opportunity about mental health to bring up testosterone because a lot of women feel much better on testosterone too. We know from the literature that it's really great for hypoactive sexual desire disorder or low libido, right? Which a lot of women experience. And honestly, Kevin, we could have a whole podcast on sexual wellness and sexual health. But so testosterone really great for libido, but we also know it's really great for body composition and muscle strength and really good for mood. Like it's a little bit of an elevator for people with mood and that energy feeling. So women struggle with anxiety and depression, absolutely need to reach out and talk to someone about it and consider hormone therapy or some other modality, right? Some other, you need an antidepressant or whatever, but you're not imagining it. I would say to women, this is really going on and really important to address.
Before we leave this topic, you mentioned testosterone there. And has that been controversial for women? Has testosterone been one of those things that the medical community is just not quite willing to accept?
Yeah, I think they're not getting it right yet. We're getting close because I would say the people on social media who are menopause experts are on it themselves and talking about it. And that's huge. And so, forever it was like, oh no, don't go on testosterone. You'll get big muscles, you'll get black hair, voice will deepen. But if you keep a woman in the therapeutic range of free testosterone, a lab value, and this is the one lab I always get is testosterone. If you get them in the therapeutic level and not above, they feel great. They don't have black hair. They don't have crazy muscles. They don't have whatever. They feel amazing. And I think it's just slowly starting to come around, but absolutely, historically, testosterone was a big no-no. We don't have an FDA-approved testosterone for women. So that is something that has to be compounded unless you use the FDA-approved for men off-label. But then it's 1/10 the dose. It's kind of messy. I usually just compound it. But absolutely, testosterone is, I think, slowly making its way more into mainstream. And the more people talk about it, then the more people will learn about it and start using it.
Sarah, I think a lot of people will wonder whether or not hormone therapy is covered by insurance.
Yeah, great question. It should be. I mean, if you are perimenopausal and menopausal, your doctor's prescribing it, FDA-approved pharmaceutical hormone therapy should be covered by insurance like any other medication. If you're going to go a compounded route, that will not typically be covered. Maybe you can use your HSA or FSA to cover it. And that usually runs, compounded is anywhere from $50 to $80 for 1 to 2 months of hormones. So typically, yes, insurance should cover it. It's medication prescribed by your doctor or your provider.
You have been extraordinarily generous with your time. I really enjoyed this conversation. It's been a lot of fun. We've been through things like not all wandering is lost down to wrapping here with things like testosterone and protein and Tabata exercising. To wrap, are there a couple of books that you might recommend to people if they want to go deeper?
Yes. So Mary Claire Haver is a OBGYN out of Galveston, Texas. She's all over the place in terms of promoting education and awareness and advocacy for menopause. She wrote a great book that is a very deep dive. So I think for women who are, sort of starting off on this journey, want the whole background and all the information, that is a great book to start with. It's called The New Menopause, Mary Claire Haver, MD. And then the other one I love is Dr. Lisa Mosconi. She's PhD neuroscience. She's incredible. And she has a great educational background in nutrition. So her book is The Menopause Brain. And I loved it because it goes through the science of what is happening to our brains. Like, why do we get spacey? What's the brain fog? What's the risk of dementia? She's doing amazing research too about MRIs. She's doing MRIs on women in menopause. Anyway, she's great. That book is incredible. And then Dr. Stacy Sims' Next Level is a great one for nutrition and exercise, the SIT, the sprint intervals, time-restricted eating, adaptogens. She covers a lot in that. And all of these women are incredible and they are on social media. You can follow them. They have podcasts, all of that. But they are a wealth of information and those books are a really good place to start.
And we will be sure to drop all of that information into our show notes because that was a lot of great information. Sarah Della Torre, thank you so much for joining me today. I have deeply enjoyed this conversation. And I'd love to have you back.
Thanks, Kevin. That was really fun.
Thanks to all of you for listening. I want to hear your thoughts about the episode. Do you have any questions? Are there topics that I should cover? If so, please leave me a comment on my YouTube channel. Find me on YouTube at Sick Health with Kevin Ban, MD. That's our show for today. The show was produced by me and Batsheva Gez. Until next time, be well.